femoral nerve block. It is the largest branch of the lumbar plexus, which is from the posterior division of the ventral ramus of L234. It is part of an on-arrival block. It is also a component of a plan A block. It helps for positioning of the patient. We can use it for positioning before spinal or epidural, for hip fracture analgesia, and for surgeries on femur, patella, and knee. So as we can see, the femoral nerve, this is the cut section, which is the thickest nerve of the lumbar plexus. And in this image, we need to understand that just below the inguinal ligament, it further divides into the anterior and the posterior division. This is the classical anatomy, the van arrangement, which all of us know from medial to lateral. At the level of the inguinal crease, we can see this is the femoral canal. The nerve lies lateral to it and deeper to both the fascia lata and the fascia iliaca. This is the dermatomal, myotomal, and the osteotomal coverage, which we achieve with the femoral nerve. Again, the ergonomics, we can use a linear or a curvilinear probe. The patient would be supine with high in-slight abduction with external rotation. And as we see from medial to lateral, this is the femoral vein, femoral artery, and this is the hyperechoic femoral nerve, which is lying above the iliacus muscle. So the needle will come from the lateral edge and we need to pierce both the fascia lata and fascia iliaca and deposit the local anesthetic. Around 20 ml of local anesthetic is sufficient. Depending on whether we need to give an analgesic or anesthetic block, we need to determine the concentration. This is another video scanning which is showing again the femoral region. And now as you can see, the femoral nerve is giving the profunda femoris branch. So the importance of this is we need to give a femoral nerve block before the profunda femoris branch comes out of the femoral artery, because at that level it implicates that the femoral nerve has divided into its anterior and posterior branches. This is the drug distribution around the femoral nerve, which we can see. Now coming to the lateral femoral cutaneous nerve, it is the sensory nerve which arises from the dorsal divisions of the L2 and L3. As we can see here, it lies lateral to the sartorius and medial to the tensor fascia lata, and it tends to run inferomedially, again giving the multiple branches. So it is usually given in surgeries requiring incision over upper lateral thigh. We can use it for skin grafting at the lateral thigh. This is the picture which shows that below the inguinal ligament, the nerve is very small and it lies between the sartorius and the tensor fascia lata. Again, the ergonomics are similar to the femoral nerve block. And as we can see, we can scan from medial to lateral. So in this ultrasound image, I'm going from medial to lateral. So this is the iliopsoas muscle. As I move more laterally, this is the sartorius, which has started to come in picture. Now, this is the tensor fascia lata, and this is the target area for the lateral femoral cutaneous nerve. In this video, as you can see, I've reduced the depth at that level, and we will definitely see a nice picture of the lateral femoral cutaneous nerve. So this is the fat-filled tunnel, and we can, if you can appreciate, these are the two further divisions of the lateral femoral cutaneous nerve, which we can determine in this image. So the nerve we can use in plane or out of plane. Around 5 to 6 ml of local anesthetic is sufficient. Coming to the third block is the obturator nerve block. It is derived from the anterior division of the ventral rami of L234. It comes out of the obturator foramen and then gives an anterior and the posterior branch. So this is the dermatomal, myotomal, and the osteotomal coverage. As we can see, it covers the medial aspect of the thigh and mostly the adductor muscles and the medial aspect of the femur. So usually we are giving isolated obturator block in mainly patients of a TURBT who have a tumor at the lateral wall of the urinary bladder, and it can be combined in patients requiring hip and knee analgesia. This is a cut section of the thigh showing the anterior and the posterior branch of the obturator nerve between the adductor longus magnus and the brevis muscle. So as I mentioned, after coming out of the obturator foramen, it divides into the anterior and the posterior branch. So depending upon the probe position at which we are scanning the obturator nerve, the visualization will be different. So at this level, it is just coming out of the obturator foramen, just beneath the pectineus. Now this is the obturator nerve. It is branching into the anterior and the posterior branches. Ergonomics again remain the same. So now from the femoral level, I'll be going more medially, as we can see in this video. As I'm moving more medially, we'll see the adductor longus, brevis, and the magnus muscle, and the obturator nerve. As I move more cranial to caudal, comes out of the foramen and divides into the posterior branch and the anterior branch between the adductor longus, brevis, and the magnus muscle. So around 10 to 15 ml of local anesthetic at each level. For the posterior branch and the anterior branch is desirable. It is recommended to give the posterior branch before so that it is more deeper, and then you can come out and give the drug at the between the adductor longus and the adductor magnus. Now coming to the fascia iliaca, there are two approaches which has been described, the suprainguinal and the infrainguinal. So the advantage of suprainguinal approach is that the studies say that 100% blocks the femoral nerve and the lateral femoral cutaneous nerve, may or may not block the obturator nerve. Compared to the infrainguinal, studies do say that it blocks 100% femoral, which may or may not block lateral femoral cutaneous nerve and obturator nerve. This is because the lateral femoral cutaneous nerve lies above the fascia iliaca and beneath the fascia lata below the inguinal crease. So as we can see in this image, at this level, if we give the drug, it will be the suprainguinal fascia iliaca, and below the inguinal ligament, it will be the infrainguinal. This is the ultrasound probe position, which shows the image. So now let us start with the infrainguinal fascia iliaca approach. Usually linear probe is sufficient, since again it's a fascial plane block. Around 25 to 30 ml of local anesthetic is needed. You can go up to 40 ml. So as similar to the femoral nerve block, as I tend to move more laterally, see the femoral vein, artery, the femoral nerve. This is the iliopsoas muscle, and deposit the nerve lateral to the femoral nerve just after piercing the fascia iliaca, and this is an indirect approach to block the femoral nerve block. So as you can see, the local anesthetic tends to move more medially and block the femoral nerve. Coming to the suprainguinal fascia iliaca approach, the block requirements and ergonomics. Ergonomics in suprainguinal fascia iliaca, again, the probe is at the anterior inferior iliac spine, and the person performing the block and the transducer and the machine should be in a straight line. You can use a high frequency or a low frequency block. We need around 30 to 40 ml of local anesthetic, and the patient is usually positioned supine with hips and knee extended. So probe maneuvering for suprainguinal, again, there are two ways. You can put the probe at the anterior superior iliac spine and move inferomedially, and you can again go from below upwards. So as you can see the sonoanatomy, this is the anterior inferior iliac spine, this is the iliacus, the cranial end is showing the internal oblique, and the sartorius is caudally, this is the deep circumflex iliac artery. So in the subsequent image, I'll be showing the pulsations, and this is the typical hourglass pattern which has, or a bow tie pattern which has been described. So this is how the needle comes. So now I am at the anterior superior iliac spine. Since it's a bony structure, it is casting a black shadow. As I move more inferiorly, this is the anterior inferior iliac spine. This is the iliacus. Cranially is the internal oblique. This is the sartorius muscle. Again, as I move cranially, it is the anterior superior iliac spine. Now, I've highlighted the pulsations of the deep circumflex iliac artery in this picture. The needle is coming from the caudal end. So the first injection which has happened is the intramuscular. As I move more cranially, I just want to go and pierce the fascia iliaca. But again, the second injection is intramuscular. So I am withdrawing the needle. I am repositioning it. We can appreciate a classic pop which I felt. And now as we can see the classical unzippering effect of the local anesthetic or the layering out effect. So the local anesthetic is going beneath the deep circumflex iliac artery. So this is our target. The complications with the CP block, which is very little, literature is still available, could be hematomas at the injection points, intravascular injection. There could be bladder rupture and pneumoperitoneum, which is rare but reported. However, the drawback is it could not be given with the ultrasound. It can lead to quadriceps and adductor weakness. The tips is always palpate the ESIS and put the probe immediately medial, slide the transducer 3 to 4 centimeter inferior. The needle tip has to be capillary to the pelvic brim. prevent spilling of the drug back down into the thigh, and it will move more cranially, and the upward movement of the deep circumflex iliac artery is desirable. Now coming to the subsartorial block, this is an excellent article which describes, and from this I have taken most of my images. So for this, we need to know the anatomy of the anterior thigh. All of us know the femoral triangle is the boundaries. The cranial is by the inguinal ligament. The medial is by the medial border of the adductor longus, and lateral is the medial border of the sartorius. So these are the boundaries of the femoral triangle. And the adductor canal starts from the apex of the femoral triangle. It runs beneath the sartorius muscle and then opens in the adductor hiatus, which is an opening in the adductor magnus muscle. So this is the picture which is showing the femoral triangle, and now the sartorius is removed. This is the picture showing the vastoadductor membrane which separates the nerve to vastus medialis from the adductor canal at the level of adductor canal. This is the cut section of the thigh showing the adductor canal. So as we can see in this picture, the boundaries, the roof is formed by the sartorius. The laterally we have vastus medialis, medially we have the adductor longus and the thick vastoadductor membrane which separates the subsartorial plexus and nerve to vastus medialis from the saphenous nerve. So the components of the subsartorial plexus are the infrapatellar branch of the saphenous nerve, anterior division of the obturator nerve, the medial femoral cutaneous nerve, and nerve to vastus medialis. And the contents of the adductor canal, the saphenous nerve, the femoral artery, and the femoral vein. And this is the relation how the saphenous nerve crosses in the adductor canal from lateral to the medial aspect. This is the dermatomal, myotomal, and the osteotomal coverage. The ergonomics remain same. This is the picture which shows the visualization of the structures at the level of the femoral triangle, at the level of adductor canal, and as you tend to go more caudally. So, as I mentioned, at the apex of the femoral triangle, will show in this picture, is formed by the medial border of the sartorius and the medial border of the adductor longus. So this structure in the ultrasound image will be seen like figure of 3. The medial border of the sartorius and the medial border of the adductor longus. Now, if I move my transducer more cranially, I'll be in the distal femoral triangle, and this appearance has been described as a half-beak pattern. And as I move my transducer more caudally, this is the proximal adductor canal, and this appearance has been described as a shark head pattern with the eye. So this is a picture, the ultrasound image. I am at the apex of the femoral triangle here. As I tend to move my transducer more cranially, this is the distal femoral triangle. And as I move more caudally, this is the proximal adductor canal. As we can see in this picture, the needle is coming from the lateral end. We are depositing the local anesthetic after piercing the sartorius muscle. As you can see, the hypoechoic local anesthetic. So it is trying to depress the pulsatile femoral artery. So we tend to deposit around 15 to 20 ml of local anesthetic if we are giving a single shot block. So this is another image which I wanted to show. We usually put catheters in all our patients, and here as we can see the catheter has migrated. It is not lying in the adductor canal. So we resited the catheter. This is the catheter movement which you can appreciate. And this video is showing the classical depression of the femoral artery injection of the local anesthetic in the adductor canal. So what is dual subsartorial? It is again 2 injections, like 1 injection at the distal femoral triangle, about 10 to 15 ml of the local anesthetic, and the second is at the proximal adductor canal. So the distal femoral triangle, it will block the nerve to vastus medialis, saphenous nerve, and the subsartorial plexus. And the proximal adductor canal, as we are depositing the local anesthetic, it seeps through the adductor hiatus into the popliteal plexus and it blocks the popliteal plexus. So the advantage of the dual subsartorial is that both the anterior and the posterior compartment of the knee innervation are being covered. Coming to the next, the iPACK, which is the infiltration between the popliteal artery and the capsule of the knee. It is mainly used for the analgesia after TKR or posterior knee surgeries. Local anesthetic volume around 15 to 20 ml. And it is infiltrated between the posterior surface of the shaft of femur and the popliteal vessel. So this is the knee innervation, the anterior knee and the posterior knee. So all of us know the anterior knee is innervated by genicular nerves along with the nerve to vastus medialis, intermedius, and nerve to vastus lateralis. The posterior knee usually receives the articular branches from the tibial nerve, common peroneal nerve, and the posterior division of the obturator nerve. So for iPACK, we can put the patient in the lateral position and flex the knee, or in the prone position. There are two approaches again which has been described. The first approach, which this was described by Professor Sanjay Sinha. So with the knee little flexed, we keep the probe at the lower aspect of the knee. This is the femur hyperechoic shadow, which we can see on the lateral aspect. And the needle comes from above, and we tend to deposit the local anesthetic between the popliteal vessels and the capsule of the knee. So this is the needle image which we can see. This is the posterior approach. As we can see, the needle is which is similar to the popliteosciatic, but we tend to move the probe more cranially till we see the posterior shaft of femur and we deposit the local anesthetic. So this is a scanning, as we can see, with a linear probe. This is the posterior component, this is the anterior. These are the two condyles of the femur. As I tend to move my probe cranially, the condyles, the appearance of the condyle will change to a continuous hyperechoic straight line, which is the posterior shaft of the femur. The needle is inserted either from the lateral or the medial aspect. And this is the similar image with a curvilinear probe. So with a curvilinear probe, we can definitely appreciate the condyles more better. And as I tend to move more cranially, this is the posterior aspect of the shaft of femur. And again, the needle can come either from the medial or the lateral aspect. Now coming to the last part, the popliteosciatic block. This is the block of the sciatic nerve at the popliteal fossa, which is mainly indicated for the distal limb surgeries, for foot and ankle surgery or analgesia after major knee surgery. Around 15 to 20 ml of local anesthetic is sufficient. And we tend to deposit the local anesthetic between the sciatic nerve sheath, the point at which the sciatic nerve bifurcates into the tibial and the common peroneal nerve. And it is also called as a Broca's sheath. This is the popliteal fossa as we see from the posterior end. So on the medial aspect, we have the semimembranosus, semitendinosus. Laterally, we have the biceps femoris. This is the tibial nerve and the common peroneal nerve. This is a dermatomal, myotomal, and the osteotomal coverage. As you can see, the medial aspect is not covered. So we need to add a saphenous nerve block along with that. We can do it in multiple positions, the supine position, prone position, and so on, or in the lateral position. The ultrasound probe, we tend to keep the probe at the popliteal fossa and move the transducer more cranially till the time we see bifurcation of the sciatic nerve into the tibial and the common peroneal nerve. And we deposit the nerve by piercing the paraneural sheath. We can do it via in-plane or a out-of-plane approach. And this is a picture which is showing the classical local anesthetic deposition around the both the component. So we need to deposit the drug in the subepimysial perineural compartment. We tend to puncture the paraneural sheath and deposit the drug, the local anesthetic, which covers both the tibial and the common peroneal nerve. So this is the ultrasound image. As you can see while scanning, this is the sciatic nerve. And as I go down, divides into two. This is the medial, the larger component, which is a tibial nerve, and laterally is the common peroneal nerve. The needle again we can put from the lateral or the medial aspect. We can go in plane or out of plane. In this picture, again the classic appearance of the paraneural sheath as we move up and down, and the sciatic nerve dividing into the tibial and the common peroneal component. And this is the needling. As we can see, the needle is coming from left side of the screen. Just getting a classical pop. As I tend to deposit the local anesthetic, it will cover both the components. So to conclude, the lower limb blocks, the plexus blocks are the advanced blocks. They are deep and we need to follow the ASRA guidelines if the patient is on anticoagulants. Most of the blocks of the lower limb, we are using it for analgesia. We tend to use the distal blocks as much as feasible because we are opting for an early ambulation for most of our patients. We tend to do motor sparing blocks, usually follow the ERAS protocols. I usually recommend the triple monitoring. Most of the blocks are large volume blocks, so always keep a watch for local anesthetic systemic toxicity. Just I'd like to discuss two cases which will to end. So this was a 36-year-old female, primary 26 weeks of gestation, who came for a 4-foot debridement and amputation of the great toe. She had multiple other comorbidities. In that patient, the popliteosciatic block was given by another person, but on incision, the patient had a pain. So what was missed in this case was we need to block the femoral nerve or the saphenous nerve. So after addition of 5 to 10 ml of local anesthetic, at that level, the patient's pain disappeared and we were able to continue the case only under block. In this patient, the general anesthesia was definitely to be avoided and we finished the case. So the importance of this is we need to know the dermatomal, myotomal and osteotomal coverage. Similar to that, this is another patient, 85-year-old with multiple comorbidities, came for an unsymmetric bipolar. Patient was given USG plus PNS lumbar and sacral plexus. Block adequate level was achieved, but there was still pain on incision. This was because the incision was more posterior, and as we all know, the cluneal nerves tend to supply that area, and it also receives the innervation from the subcostal nerve. So sometimes in cases with bipolar or THR, we need to ask a surgeon what is the site of incision, and thereby, if needed, we can add a local anesthetic at that level. Thank you so much.